A very good morning to everyone. My name is R. Jaya Siglan. I am a Bachelor of Medical Health Science student in OUM PJ campus. I am in semester 6, which starts from September 2021. So we have a assignment to do a one case study while doing practical in emergency department. So the hospital I did in my own hospital, which is I'm working now, emergency department in hospital Kajang. The topic I took is a neck of femur fracture in osteoporotic bone. I start my practical on 6th of November, which is I already informed my HOD to do practical with my colleagues and also my senior. So I'll do in pre-hospital care, start from 6th of November until 8th of December. It's not the same day, but it is on and off days. Okay, for the introduction, osteoporosis means porous bone or less bone mass. So it can lead to high risk of bone fracture. Common is a neck of femur fracture in old people or elderly people. So the holes in the sponge grow large and larger, then weaken the inside the bone. So now you can see the picture in the here. This is the healthy bone or the bone for the young people. So you can see the quality here is very good. So not much of holes. So this is for the osteoporotic bone or the elderly people. You can see here a lot of holes, same as they mentioned here. The holes in the sponge. You can see a lot of difference between these two bones. So it is very fragile and easily break or fracture. So even though it's a low energy of impact. This is the anatomy of femur bone. Femur bone is located at the leg, at the thigh. So the anatomy is comes with head, neck, greater trochanter, lesser trochanter, intertrochanter, shaft, medial and lateral condyle, medial and lateral epicondyle, intercondylar fossa. So this picture you can't see clearly what is labeling here. So I already divide to the upper and the lower part from the bone, femur bone. Okay, this is the upper part. You can see the head is here. If got head, sure there is a neck. So neck of femur. This is the greater trochanter, which is can see big a bit. This is a lesser trochanter, is the medial side of the femur, and the intertrochanteric line. Okay, this is the intertrochanteric. What fracture here is the IT fracture or intertrochanteric fracture. Okay, the long bone we call is a shaft. Okay, from the upper to the lower part there's a shaft. Okay, this is the lower part of the femur, which is medial epicondyle, adductor tubercle, medial condyle, lateral condyle, and lateral epicondyle. So this is a joint. This is the joint, upper joint of the femur, which is head comes with acetabular. So we call hip joint. It's a socket here. And for the lower part of the femur, you can see there's a knee joint. Knee joint comes with patella here, patella bone, and on the medial side there's a tibial bone, and the lateral part you can see there's a fibula bone. This is the hip joint, knee joint. I hope everyone clear this one. Okay, for come for the case presentation on the 9th of November, which is the day of my practical. There's an ambulance call at 8:30 morning. We received an ambulance call from MACC Serdang. So Kajang Hospital is a cluster under Hospital Serdang. So MACC means Medical Emergency Coordinating Center. So if you call 999 at the Klang Valley, the near to the Kajang or Serdang, they will divert to Serdang first. So they will dispatch the call to the near hospital or clinic kesihatan nearby. That's how the base system is run about. Okay, that case is a 69 years old Chinese old man fall in market at Sungai Chua, Kajang. Okay, patient's condition: patient is alert, conscious, left leg pain and unable to move or wake up. So patient, okay, this case was activated by public. It means I think there's no family member. If not, someone will call. And you can see clearly the patient just fell down only. It's not an accident. But the thing is, the age we should concern here, 69 years old, and fell down and leg pain. But fortunately, the patient is still alert and conscious. So once reach the call, follow the KPI. Within 5 minutes, we already respond the case, move from the hospital. The Sungai Chua is about 10 to 15 minutes from Kajang Hospital. Okay, this is the patient's detail. Patient, I didn't mention his name. I put as a Mr. S. Patient age was as mentioned in MACC, 69 years old. Patient is a Chinese man. The comorbid is patient has hypertension and bilateral knee OA. OA means osteoarthritis. Okay, patient is followed up under Kajang Hospital itself. He is followed up under medical outpatient department and orthopedic clinic. So patient vital sign looks stable. The BP you can see here 169 over 96 millimeter mercury. So for the hypertension patient, I think this is okay. Maybe patient in pain, that's why the BP is a bit high. The heart rate is normal, 69 beats per minute, and the respiratory rate was 20 per minute. The oxygen level saturation is about 98% under room air, and patient pain score was 6 to 7 over 10, and patient denied of any allergic to medication. Okay, in documentation and assessment finding, why the documentation is very important in this kind of medical legal cases. So any sue or any queries from the relative or from others, so first thing they will see our documentation. That's why documentation is very important. And whenever we didn't document itself, it means we didn't inspect or didn't do that thing. Okay, patient, when we reach, patient is alert, conscious, GCS also full, and patient complain of groin pain and unable to lift the left leg. And clinically, when we found the patient on the floor, we can see patient is left leg was shortening, externally rotation, and abducted in supine position. When he lie down supine position, the leg is like this. But actually this photo I take from the Google, because it's not suitable to take a picture when in front of public, because it's not nice and patients sometimes can complain also. So I took this picture as an example from the Google. So clearly we can see what is the clinical finding in neck of femur fracture or femur fracture. Okay, on-site treatment, what we did when we reached there. Okay, when she did deformity, so straight away we feel the pulse, and the distal pulse, popliteal artery, posterior tibial artery, and dorsalis pediatry are palpable. So we put patient on lower limb hairspline and cervical collar. Even though patient didn't complain of any cervical tenderness, it's a must in trauma cases. And as a maintenance, we put IV cannula size 18G and normal saline IV drip maintenance. I cannot run fast because patient having hypertension, and maintenance is just to prevent of any fat embolism. For the long bone, there's a complication of fat embolism, so it's better to put the saline to dilute it. For the treatment in ED, within 10 to 15 minutes, we already reach emergency department, hospital Kajang, and patient still alert and conscious. The MA, medical assistant in triage, take the patient to the yellow zone. So we put patient in yellow zone, bed number 8. I already pass over the case to Dr. Nita, who is already in charge in yellow zone. So patient looks stable, no problem. So myself with my houseman and the MO, we did a lock roll for secondary survey. So we already opened up his t-shirt, the pants, everything, and changed to the hospital suit, patient suit. And no wound found at the back, no spinal tenderness, no cervical tenderness, no bleeding, ENT bleeding. Patient alert conscious, and patient giving his history nicely to the doctor. And pain score still same 6 to 7, so doctor decided to give IV morphine 2 mg. And for the blood baseline blood investigation, as we did, we do full blood count, and once the pain score is reduced, we send the patient for X-ray with the stretcher and the splint. We applied the splint. So this is the X-ray finding after patient come from the X-ray department. So the basic X-ray we did was chest X-ray, but I didn't put here because it looked normal, sorry. And for this one we did a pelvic X-ray, a right hip joint X-ray, and the left hip joint X-ray and left lateral femur. So here clearly we can see the fracture here on the right side. You can clearly see the neck of the femur. On the left side it is a bit shortening here, so the femur bone is already overlapping the head of femur. I think you can see clearly here. No other fractures here. Suprarami was look normal, no fracture. So the case was referred to orthopedic team. So for your kind information, so the medical and surgical treatment. So what is the blood supply in the neck of femur or the hip joint? Okay, the blood supply to bone is delivered to the endosteal cavity by nutrient arteries, then flows through marrow sinusoids before existing via numerous small vessels. For femur bone, medial femoral circumflex artery is the chief source of blood supply or vascular supply to the femoral head. So you can understand, it's a very clear sentences. Okay, most common complication of neck of femur is a avascular necrosis. This is very important, avascular necrosis. Okay, now we're going to see the anatomy in the picture. It is very clear. You can see the medial femoral circumflex artery. This is the artery which is go to the head of femur. If this one is cut or there's a blood supply was blocked, the head easily can be necrosis, which is the condition we call avascular necrosis. It's a common complication in neck of femur fracture. Okay, what is the classification of the neck of femur fracture? Here, the common classification, the easiest to understand and to apply is a garden classification. There's a lot of classification for other fracture in orthopedics, like near classification. Smith fracture is a classification also. Okay, other than that, okay, this is the type 1, type 2, type 3, type 4. Okay, type 1, you can see there's a fracture at the neck of femur, but it's not complete fracture and not displaced. And this one is a complete fracture but not displaced. The type 3 is a partially displaced and also a complete fracture, and this is a complete fracture neck of femur with totally displaced or fully displaced. So I summarize the classification here in this diagram. Okay, you can see type 1 incomplete fracture with valgus impacted is a non-displaced fracture. Type 2 is a complete fracture, non-displaced, and type 3 is a complete fracture, partial displaced, and the type 4 is a complete fracture with fully displaced. Easy to understand as long you know the anatomy and can interpret the X-ray. Okay, how about the treatment? So for the neck of femur, we are suggest open reduction internal fixation, or we call ORIF. ORIF includes cannulated screw, dynamic hip screws, proximal femoral locking plates and also cephalomedullary nails. This is one for the young patient with neck of femur fracture. Not necessary only elder patient will get neck of femur fracture. With high impact like motor vehicle accident, fall from heights, is can get a fracture also. So for the elderly people, hemiarthroplasty, total limb arthroplasty, HTA, and internal fixation are very common in neck of femur fracture. Okay, this is the patient I follow up. The patient was the operation or surgery after 4 days of admission. They already discussed with the family member and they agreed. So in 4 days of injury, they put on hemiarthroplasty brand Austin. So this is, you can see hemiarthroplasty on the left side of the femur. To complete the head, they remove the head and replace with hemiarthroplasty. So there's no head of femur here. You can see, no head of femur. They replace with hemiarthroplasty. Okay, for the safe surgery, for the safe patient, as you all know, international patient safety goals are and to ensure safe surgery is very important to reduce the risk of patient while doing surgery. So it's very important. It's not about how fast we did the operation, but how safe we did the operation. And also wound care, pain management, antibiotics to avoid the infection rate, and tight stockings to prevent blood clots. Okay, whenever patient plan to discharge, it's very important to advise and educate the patient or the family member. It's very important. So what we should advise to the patient or relatives. Okay, first, incision open, the stitches are open. Make sure they come back to us, either to the clinic orthopedic, or at night after the office hour come to emergency department, so the orthopedic surgeon or medic doctor can review the wound. So increase redness as incision site. The increased redness, it means there's an infection in the wound at the wound site. Okay, the uncontrolled pain after taking medication. Okay, this is also very important. Okay, we cannot advise patient to take more painkillers if there's more pain. If let's say they're taking medication, painkiller, they're still having a pain, it's better to come back to us to review the wound and do the repeat x-ray. Maybe sometimes there's some displacement, or there's a hip dislocation, or there are some choices or option they could be. So the bleeding from the wound and fever. Fever is same like as I mentioned. Increased redness, it means the infection. If there's infection, there's a fever. Sign of infection is a fever. Okay, and difficult to breathing or chest pain is also must be considered. For the severe pain or redness in calf, we suspect of any like compartment syndrome, like that, and also infection in the muscles. Painful swelling, very painful and swelling. These both are related to compartment syndrome. It can be. This is the tight stockings that I already mentioned just now. It will be from the foot until the thigh. Okay, you can see the bruise are here. Okay, this one you can see the wound is look clean. There's a bit blood accumulation here. So for me, I think the wound is better, but this is not the patient. This one all from the Google pictures, and this is the fever lah. Okay, identification, clinical diagnosis, and intervention. So deformity is very important to identify. So as a paramedic, for respond the case in ambulance team, is must to know and have a skill and the knowledge how to identify the deformities. For example, patient look pale is a deformity. Patient having dinner fork deformity, there's maybe a collis fracture or distal or radius ulnar fracture. Same like there's the case I show you just now, presented with shortening leg, external leg rotation. Can suspect of femur fracture. Shoulder dislocation, how is the position of the patient in shoulder dislocation. History taking and physical examination is very important also. So by the proper history taking and physical examination, 90% we can assume what is the problem or diagnosis of the patient. So patient normally complain pain is predominantly in the groin and thigh. This is for the neck or femur fracture, or also acetabular fracture. Elderly patient with the low energy of impact, like fell down, they easily can break the bone. So we cannot simply assume it's a soft tissue injury or patient is okay. In distal neurovascular deficits are very rare in this case. Fortunately this is not happen in the neurovascular deficits in neck or femur fracture. Common femur fracture, what are the neurological deficits we are seeing is foot drop. The documentation of foot drop is very important when first we are seeing the patient and assess the patient. The neck of femur fracture can easily diagnose with plain radiograph. Yes, to diagnose this one is enough to do a radiograph, and not necessary urgently we need a CT scan or MRI. Okay, for this neck of femur fracture case, the differential diagnosis are what I found in the journals and the articles. The pelvic fracture, especially pubic ramus fracture. Pubic ramus fracture, just now as I mentioned, sometimes the doctors are miss fracture because they more focusly on the neck of femur or head of femur fractures, so they will miss fracture this one. And femoral head fracture, this one sometimes you cannot find with the X-ray itself. It's need a CT scan to find out. Sometimes patient come with neck and also head of femur fracture. It could be happen for the acetabular fracture. For the old patient, elderly patient, the visual of the X-ray is not that clear. So sometimes we can miss fracture also. And the hip dislocation, not only the fracture, dislocation is one of the main thing we must concentrate in when interpret the X-ray. Dislocation also could happen. Why? Because the joints are wasting, and the old people, maybe you can see, is very skinny, so the strengthening of the joints are very low. So when once they fell down, it's easily dislocated. Or not only joint, the muscle are very important to hold the bone with at the joints. Okay, about the osteoarthritis. Osteoarthritis, as I mentioned just now, as happen in the knee, the hip also could happen as a osteoarthritis. So sometimes patient is a chronic pain. When he fell down, they come back to us, when do the X-ray, we didn't see anything, maybe you can refer to the orthopedic team, because there's a chronic arthritis patient, didn't have any follow-up or treatment for that. So we have to rule out all these things in differential diagnosis. So for as a conclusion, neck of femur fracture are very common in elderly people, as I mentioned, because they are osteoporosis and didn't need any like trauma or high energy impact to get a fracture as young people, and high impact on their quality of life in functional status. We must remember, once the patient had a fracture, they will really impact their quality life. They cannot walk, they will lie down, the family member will put them in one place, in one room, so no one to take care of them. Then patient can lead to dementia like that, or any infection rate, bed sore, aspiration pneumonia. Okay, that's the quality of life and functional status. Easily identified by the deformity of shortening external rotated and abducted in the supine position leg. This is I mentioned at earlier. This is very important in femur fracture, how to identify and what is the deformity, shortening, externally rotated and abducted in supine position. Okay, immobilization is very important to relieve pain and complication. Okay, immobilization better is a traction, when patient are admit with femur fracture, before operation, what we do, we will put on skin traction with 3 kilo weight to track the bone and maintain the alignment. It's very important. You cannot simply put the patient in splint for so long. So skin traction one of the normal option for the femur fracture while waiting for the surgeries. Okay, Garden classification is to classify a neck of femur fracture. This is, I mentioned just now, I explained very well. It's very easy to understand. So MM arthroplasty and total hip arthroplasty HTA are used to elderly people. So I think this operation is very easy. Not easy, it's a major operation, but these are the option for the neck of femur fracture in Garden type 3 and 4. Okay, this is my references so far, so you can review. So any question? Okay, thank you so much.